everyone. Good evening to all our participants. Our faculty for today is Dr. Nawaid Ahmed. His designation is he is the consultant chest physician in University Hospital North Midlands NHS Trust, and his area of interests are COPD, asthma, bronchiectasis, interventional pulmonology, and research. Thank you.
Okay, so good evening, everybody. So as introduced by 𝒃𝒐𝒖𝒕, I'm one of the consultant chest physicians at University Hospital North Midlands NHS Trust. And as a part of the faculty, I've been asked to go through some of the questions that you practice for your mock test. So we'll start off with the first question, which was the mock test. I hope you can all see my slide. 𝒃𝒐𝒖𝒕, can you confirm if the slides are moving?
It's visible from my end. I would suggest one of our students to please speak up if they face any issues. It is visible,
so
sir.
Okay, so the chat box is there. So if you want to just put it in the chat box, if there's any problem.
Yes, they can do that.
And 𝒃𝒐𝒖� can address that, okay?
All right.
So there is some background noise I can hear. So if everyone can mute their microphones and unmute it only when they want to speak, okay? Thank you. So we present, so the first question here, a 58-year-old gentleman presents to the general physician with a 4-month history of episodic knee pains and aching legs. And these have been occurring monthly, and episodes can last up to 3 weeks. He has noticed a rash to his lower legs and complains of feeling more lethargic than he used to be earlier, and he has no significant past medical history. He is currently obtaining methadone from a pharmacy daily. And if you look at the clinical examination, there is very little there to point you towards anything, but there are some painful in the knee movement and palpable purpura to the lower extremity. And then you are given with these investigation details, as you can see, that apart from the hemoglobin being slightly low and the complement factor being slightly low, the other parameters like AST and ALT are raised, and AST is higher than the AST measurement. The total leukocyte count is normal, and the MCV is normal. And then you are getting these 5 options. So if I go back to the question there, so you can see that there are reasons why. There are a few things that have been mentioned in the question. So the first thing is 4-month history. Okay.
So this is a question on hypertension. So 75-year-old with chronic hypertension is referred by a primary care physician to the cardiology clinic, as she is noted to have persistently elevated blood pressure over the last 4 months, despite taking oral antihypertensives. She has BMI of 26, non-smoker, but does not drink alcohol and maintains a balanced diet. There are no features to suggest a secondary cause for her hypertension. So which one of the following is the most appropriate treatment for her persistently elevated blood pressure? So again, for this question, you would need to know what is the guidelines for the management of hypertension. The guidelines suggest that if they are in that age group, you would consider using a calcium channel blocker or a thiazide diuretic. Thiazides are not mentioned in the answer, so the right answer would be a calcium channel blocker. ACE inhibitor you would not use in a 75-year-old because they may have chronic kidney disease and it may make things worse. Beta blocker is no longer recommended as a treatment of choice for hypertension. Angiotensin blocker and alpha blocker for the same reason as beta blocker that we would try not to use. So the 3 things are ACE inhibitors, calcium channel blockers, and thiazide diuretics as the first line treatment. ACE inhibitors are quite commonly used in younger population, whereas calcium channel blockers and thiazides are used to treat essential hypertension in older people. Okay, so the right answer here would be calcium channel blocker. This is a pediatric question. A 2-year-old boy with short history of blue lips and breathlessness is brought to ED by his anxious parents. His parents are panic-stricken and an urgent admission is arranged. Next day, whilst the consultant pediatrician visits the ward to see how the child is doing, looks through the notes and finds a report from a transthoracic echocardiogram. The report mentions displacement of the tricuspid valve towards the apex, a small atrialized and hyperplastic right ventricle, an ASD, and a tricuspid valve incompetence. So which one of the following is the most likely diagnosis based on the echocardiography findings? So again, this is a question where you will either know the answer or you will not know the answer, because they have almost given you the answer in the echocardiogram findings. Okay. So there is nothing to say about this basically. So the classical echocardiographic findings of 𝑨𝒃𝒐𝒖𝒕 anomaly is mentioned there. So you just have to know. So you don't have to basically go through a process of elimination. So you will either know that or you don't, because there are specific findings of 𝑨𝒃𝒐𝒖𝒕's anomaly which are mentioned in the answer. So a 78-year-old gentleman presented to the ED with palpitations for the past 6 hours. So he's having palpitations for 6 hours. 2 months ago, he suffered from weakness of the left arm and problems with his speech, which resolved within 3 hours, and he was taking no medication. So that sounds like he had a TIA then. On examination, he was tachycardic with AF, blood pressure was 110/80, and within 1 hour, he reverted to sinus rhythm. So he had a 2D echocardiogram and a 24-hour ECG, which revealed AF. Which one of the following is the most appropriate initial treatment for this gentleman? So you've got 5 options there. So in AF, obviously rhythm control is quite important. So you've got a 43-year-old gentleman who's a painter, and he presents with burning pain in both feet, which has deteriorated over the last 4 months. He admits to drinking 50 units of alcohol every week and has a family history of pernicious anemia. Again, as I said, I keep on mentioning this. There are reasons why they mention the age, why they mention the occupation, why they mention somebody is drinking alcohol. So he has impairment of all modalities of sensation in both feet, except pain, temperature, and absent ankle jabs. So which of the following is the most likely diagnosis? So this is alcoholic peripheral neuropathy. They are the most common causes of peripheral neuropathy. And the clue of peripheral neuropathy is in the fact that he's having burning feet. And the clue that this is not a case of chronic inflammatory demyelinating polyradiculopathy is when it sees that there is impairment in both feet except pain, temperature, and absent ankle. Okay. Whereas with chronic inflammatory CIDP, you would have all these problems. So because it's not CIDP, it is alcohol peripheral neuropathy. They have actually given that answer in the question itself. So they have given you a big clue there. A 65-year-old presents with an 8-month history of a gradually increasing burning sensation. It's a very similar question. So that revealed normal cranial nerves and a higher mental function. Okay. So higher mental function is normal. There are also there was also normal bulk, tone, power, light touch, and pinprick sensation, coordination, and reflexes in upper and lower lip. So everything is okay. So what are the above clinical findings consistent with which of the following diagnoses? 8-month history, gradually increasing burning sensation in her feet in a 65-year-old lady. So you've got the various options there. There is nothing to suggest Sjogren's syndrome here because there is no mention of anything else. So this is simply a small fiber sensory neuropathy. So you can immediately get rid of motor neuron disease there, because motor neuron disease you would get abnormal reflexes. Large fiber sensory neuropathy, that would definitely cause light touch and pinprick sensation to be reduced. Diabetic amyotrophy, that would again cause some problems with reflexes, etc. There is nothing to suggest Sjogren's syndrome here. There is no evidence of dry eyes, dry mouth, etc. So the only option is the small fiber sensory neuropathy. So 41-year-old has left eye pain that has deteriorated over the last week, and the patient is referred to the neurology clinic for a review. The patient has mild ptosis of the left eye and was aware of a double vision with vertical image separation or looking upwards. He also had weakness of elevation of the left eye, and the pupil was slightly larger compared to the right. Which one of the following is the most plausible diagnosis? Okay, so he's got evidence of a enlarged pupil compared to the other side. So this is a posterior communicating artery aneurysm. There is unilateral partial third nerve palsy, which is associated with periorbital pain. So of all the options given, this is the right answer, which presents with an isolated painful third nerve palsy with pupillary involvement. So if you look at it, the pupil is slightly larger compared to the right. So if there is involvement of the pupil and it is painful, it is usually a surgical thing, which is posterior communicating artery aneurysm. It cannot be myasthenia gravis because it is a unilateral problem. Okay, this is not sphenoid sinusitis. There is no evidence of any pain or discomfort around the sinuses. This is not cavernous sinus thrombosis because there are no risk factors for that. And there is nothing to mention Graves' ophthalmopathy. So the correct answer would be posterior communicating artery aneurysm. 26-year-old lady at 10 weeks of her first pregnancy presents for the first ever antenatal checkup. She has been diagnosed with epilepsy 4 years ago, which was well controlled on sodium valproate and had been taking the combined oral contraceptive pill for 2 years. So which one of the following is true concerning this lady? So again, the two things to think about here, sodium valproate and the oral contraceptive pill. So you will have to think about interactions of the two medications, okay? So what is the correct option here? So you've got the 5 options there. Yeah, so there is an increased risk of neural tube defect. So this lady has become pregnant while she's on valproate. So this therapy has controlled her seizures and should not be changed now. However, there is an increased risk of neural tube defects associated with valproate, and this could have been reduced by folate therapy early in pregnancy. Valproate is not an enzyme inducer, and unlike other anticonvulsants, would not speed up metabolism of the OCP. It is entirely up to the individual whether she wishes to pursue the pregnancy or not. So as I said in the previous question, that some patients who are already established in sodium valproate, the dictum is to carry on with them for a long term. But in the current climate, sodium valproate is not the first drug of choice in epilepsy in a young female, okay, because of the risk of neural tube defect in the fetus. Usually causes contralateral homonymous hemianopia or quadrantonopsia. It does not typically cause hemiparesis or inattention. That's a good point. So, if there is involvement of, if there is hemiparesis and inattention, then there is definitely involvement of the parietal lobe. But remember, inferior is parietal, but superior quadrantonopia would be temporal lobe. Which of the following causes demyelinating polyneuropathy? So that is hereditary motor sensory neuropathy. And again, this is something you will have to know what are the differential diagnoses of demyelinating polyneuropathy. And these are the conditions that can cause it. So you may get a straightforward question. And particularly in part 1, you will be asked this question straight away without giving you any clues, etc. So there'll be less clues in part 1, more clues when you take the part 2 exam. Axonal polyneuropathy is caused by diabetes, alcohol, vitamin deficiencies, and renal failure. So the correct answer will be hereditary motor sensory neuropathy. And you will have to look at the differential diagnosis of all the other conditions as well. A 64-year-old lady presents with a 3-day history of weakness of the right foot, being aware of a feeling of dragging the toes along the floor when she is walking. She has type 2 diabetes for the past 3 years, and on previous review, no abnormalities were noted. On examination, she is unable to dorsiflex her right foot together with eversion of the foot, and the left foot is unaffected. Plantar flexion and inversion are normal. So which sensory abnormality is expected to be present in association with this motor defect? Would there be sensory loss over the entire foot, sensory loss over the plantar aspect, sensory loss over the lateral part of the leg and dorsum of the foot, sensory loss over the big toe, or no associated sensory loss? So again, clues: type 2 diabetes for 3 years. Okay, unilateral. So this is almost like unilateral foot drop, isn't it? Because she's unable to dorsiflex it. So foot drop is there, lack of eversion is there, left foot is unaffected, and the plantar and inversion are normal. So this is basically a case of mononeuritis, monoplex, or mononeuropathy. There's a common peroneal nerve, which is very commonly involved in patients with diabetes. So this is a very classical question. Please pay attention to this question because this question will come in the exams. Okay, this is a very classical question for MRCP, and you have to remember this because there is a common peroneal nerve policy that happens in patients with diabetes. 42-year-old presents to ED with a number of episodes of rectal bleeding over the past 1 week. She describes a cup full of fresh red blood present in the toilet following defecation. So red blood after defecation. So that is an important point. Okay. but denies any pain during passing stool. She has no other past medical history of note, nor does she take any medication. She does, however, report a history of her father having bowel problems. So all her investigations, as you can see, they're all within normal limits. Let me see, albumin, hemoglobin is low, obviously, because she's having PR bleeding. Platelet count is now 1. Clinical examination, a number of small red areas are noticed on the patient's lips. They're about 0.1 centimeter in diameter, which disappear on pressure before refilling. Which of the following is the inheritance pattern of the underlying condition? So you have to know that this is hereditary hemorrhagic telangiectasia, and this would be autosomal dominant, which is option D. 31-year-old prima gravida at 6 weeks of gestation presents for an antenatal checkup. She feels all right, but blood tests show that her serum bilirubin is 38. LFTs are completely normal. So what is the most plausible diagnosis? This is very common actually in real life practices where we see that quite often. This is very likely to be Gilbert syndrome, okay, where the patient is pregnant. Intrahepatic cholestasis is relatively common, but because the LFTs are normal, it is unlikely to be that, okay. 35-year-old presents with acute profuse watery diarrhea with some blood in stools after returning from a holiday in Kenya. So this is like a traveler's diarrhea. Which of the following is the most proper treatment for this condition? It is ciprofloxacin, okay, because that is E. coli and that is sensitive to ciprofloxacin. 71-year-old is referred with abnormal liver function test and undergoes a liver biopsy. Which one of the following contradicts hepatic cirrhosis? Contradicts hepatic cirrhosis. Okay. Liver cell necrosis, subendothelial fibrosis, fibrous septa formation, nodular regeneration, granuloma formation. So B, C, and E would be suggestive of fibrosis. Let's see the answer. So the correct answer is actually E. So granuloma formation is not classically seen in cirrhosis. So you can have micro or macronodular in type. In the micronodular form, the nodules are less than 3 millimeters. In the macronodular form, there are larger nodules which are classically seen in chronic viral. So viral hepatitis or cirrhosis can be micronodular or macronodular. So granuloma is something that is not seen in liver cirrhosis. So a 52-year-old gentleman with a previous history of IV drug abuse attends the clinic for a review. Over the past few months, he has joint pains and fatigue, and he's developed a purpuric rash, which is affecting his arms, legs, and he suffered from 3 transient episodes of 7th nerve palsy in the last year. On examination, his blood pressure is normal, pulse rate is normal, and the examining physician confirms the purpuric rash and evidence of small joint synovitis. There are a number of spider nevi on the upper body, and they have some small palpable lymph nodes in both axilla. So again, looking at the blood test results. Looking at the blood test results, you've got slightly low platelet count, creatinine is slightly high, and ALT is very high, alphas is high, bilirubin is normal, cryoglobulin is normal, and the chest X-ray is normal. So again, to summarize, IV drug abuse, big blue, okay? Joint pains, fatigue, big blue. Transient episode of 7th nerve palsy in the last year. So what is the correct answer here? This is likely to be hepatitis C. And again, it is associated with cryoglobulinemia. So as you can see, there are 2 questions in this mock exam which are based on hepatitis C, which indicates that you have to make sure that you are perfectly okay with this question, okay? So mixed cryoglobulinemia is seen in hepatitis C, and that is the result of, and this question we can see that there are other clues to hepatitis C as well, particularly with the mention of an IV drug abuse. Thank you very much.